Hello, I'm Dr. Pratyusha. Today I'm here to discuss the topic postnatal pregnancy and also give a uh, brief introduction to induction of labor. So, what is the normal duration of pregnancy? As it is around 40 weeks, that is around 280 days, is the normal duration of pregnancy. So, we have two entities now, which is post dates as well as the post term pregnancy. What is post-dated pregnancy? That is pregnancy after 40 weeks. That is after the expected date of delivery. That is post-dated pregnancy. Then we have the post-term pregnancy, that is after 42 weeks. That is 40 plus 2 weeks. That is EDD plus 14 days goes with the post-term pregnancy. So why is it important? What is happening in a post-term pregnancy? So after the 42nd week, the placenta which supplies the baby with nutrients and oxygen, it starts aging and will eventually fail. So that is why delivery before 42 weeks or by near term by EDD is important. And because of the failing placenta, there is a number of key morbidities are greater in infants born to postpartum pregnancies, including meconium, staining of the liquor, aspiration of the meconium leading to meconium aspiration syndrome, neonatal acidemia, low Apgar scores, macrosomia, and in turn birth injury as well as the instrumental deliveries. But as such, there is increase in perinatal mortality also in a post-term pregnancy. So that is why the topic post-term pregnancy is of clinical importance. So what is the cause of post-term? So most of the times the causes is unknown, but there are few factors which can imply. That is, the maternal factors are primiparity, sedentary habit, elderly multipara, and a previous post-term birth. So these are the maternal factors which also contribute to a post-term pregnancy. Then we have the wrong dates. This is the most important thing, that is, due dates are easily miscalculated when the mother is unsure of her last menstrual period. So in reality, the baby is not technically post mature. So when will this happen? When the mother has irregular cycles, or she is in lactational amenorrhea, there is no previous dating scan, previous history of usage of OC pills. In such cases, she might not be able to give a correct last normal menstrual period date, and in such cases, there will be a chance of wrong dates, and the post maturity or the preterm risk is high. It is like a both edges, either post maturity or a preterm. So that is the importance of knowing the correct dates of the mother, either by her last menstrual period, or if she is unsure, as early as you know that she is pregnant, go for the dating scan in the first trimester. That will be of great use. Then we have the fetal factors, that is the anencephaly as well as the adrenal hypoplasia. So both anencephaly as well as the adrenal hypoplasia, they have their influence on the fetal adrenal axis, which in turn hypothalamus and will stimulate the process of labor. So in such conditions, there is an increased chance of post-term and post-dated pregnancies. Then we have the placental factors, that is the sulfatase deficiency, which causes less amount of estrogen in the placenta as well as less amount of prostaglandins for the initiation of labor. So these are the few factors which are implicated in causing post-dated or post-term births. So how do we diagnose that this is a post-term pregnancy? Normally, when you are seeing the woman for the first time, first visit, when we are seeing her, it is difficult to diagnose it is a term or a post-term pregnancy. So when we are seeing the women at term, what are the clinical guides for us to calculate the gestational age and determine if it is a term, preterm or the post-term pregnancy? First is the menstrual history. We start by taking the menstrual history. If the cycles are regular, or any history of usage of OC pills, previous history of irregularity of the cycles, or if she is any lactation, recent delivery, all the history regarding the menstrual cycle has to be taken, and if all this is normal, we take the last normal menstrual period date. Then we have the clinical findings. Weight. So when the pregnancy is progressing from term to postterm, the weight of the woman comes down. It reduces a bit because of the reduction in the amount of liquor. So that is one thing. Abdominal girth. Same, because of the reducing amount of liquor, because of the failing placenta, the abdominal girth is also reduced. Then we proceed with the obstetric palpation with the fun of the obstetric grips. Such cases, what happens is the uterus, or it may be, or the abdomen when we are palpating, may be full of fetus because of the less amount of liquor, and the fetal skull, because of the calcification, it will be hard. It is not soft. The fetal skull, we can feel a hard velatable structure. On internal examination, that is a pervaginal examination, we can see cervical changes if present, if the patient is setting into labor. Then false pains. The patient has already had a false pains and they have subsided. Maybe she might be going into a post-dated pregnancy. So these are the few menstrual history and the clinical findings that help us to determine the gestational age, the term or post-dated in a pregnancy. Investigations. So when such woman comes to us to the antenatal clinic, first what we have to do is to confirm the fetal maturity and to detect placental maturity as well as the functioning of the placenta. So how do we confirm fetal maturity? Determination of fetal maturity is through clinical examination, as we have already noted the points, as well as with a scan, which can be based on the diameters, or it can be invasive by amniocentesis. So we will first confirm the fetal maturity, then placental maturity and fetal well-being is ascertained. Then we proceed with further management of the pregnancy. So how will you determine fetal maturity? First, clinically it is by last menstrual period. Auscultation of the fetal heart. If we have previous notes of the patient of the antenatal checkups, we can see when was the fetal heart auscultated first at the gestational age, and you can determine it as auscultation of fetal heart at 18 to 20 weeks. Height, fundal height, amount of liquor, feel of the head, that is hard, and the cervical condition. These are the clinical factors which help in determining fetal maturity. Then we have the investigations, which is non-invasive, that is ultrasound, and invasive, that is the amniocentesis. Ultrasound. So what are we going to get after the ultrasound report? So we will determine the gestational age based on the diameters. That is, we take the head circumference, the biparietal diameter, abdominal circumference, as well as the femur length. Okay. So based on these diameters, we ascertain or come to a conclusion of the gestational age. We can see also the grading of the placenta as well as the amount of liquor that is present. So all this, based on all these factors, we come to a gestational age which will determine the fetal maturity. Invasive. Though invasive, we have the amniocentesis, where we check for the lung maturation by the lecithin sphingomyelin ratio, or the bubble test, or the cells in the amniotic fluid. This is an invasive procedure, so it has its own complications. So this is the methods by clinical as well as the investigations we can determine the fetal maturity. So after we have determined the fetal maturity, now these are the signs of post-maturity after delivering the baby. So what are this? This is the dry skin. The skin becomes dry, overgrown nails, creases on the baby's palms and soles of the feet. The nails are long. The creases on the palms and soles of the feet are present, which are deep. The fat, minimal amount of fat is present. Brown, green or yellow discoloration of the skin, which might also be due to passage of the meconium. And some post-mature babies will show no or little sign of post-maturity. So these are the signs of post-maturity after birth, where you can examine the neonate and tell it is a post-mature infant. So what are the complications? Now we have ascertained the maturity of the fetus, if it is a post-mature. Why is it important? What are the fetal as well as the maternal risks that can happen in a post-dated pregnancy. Fetal risks. There is reduced placental perfusion. Because of the aging placenta and calcifications, the functioning of the placenta is reducing, where the gaseous exchange as well as the absorption function is also reduced, and the placental perfusion is reduced. Calcium is deposited on the walls of blood vessels and proteins are deposited on the surface of the placenta. So this limits the blood flow to the placenta and ultimately leads to placental insufficiency, and the fetus is no longer properly nourished. So this is the one important factor which is happening in a post-dated pregnancy that can have effect on the fetus, and it is the important cause of all the pathological changes that is occurring in a post-dated pregnancy. So when the placental perfusion is reduced, it will lead to oligoamnios where the amount of liquor is less, and which can indeed lead to fetal distress, cord compression, meconium aspiration, passage of meconium followed by meconium aspiration syndrome, and increased risk of stillbirth in the neonate, in the fetus. So these are the complications and the fetal risks of a post-term pregnancy. Then, what are the complications during labor? During labor, there is fetal hypoxia, which may be due to oligoamnias, cord compression. Okay, and we have this dysfunctional labor where because of the lack of moulding there, because the skull is hard, lack of moulding, less amount of liquor, there might be a dysfunctional labor, increased risk of instrumental delivery as well as the C-sections. Oligoamnias, cord compression, shoulder dystocia, which is due to big babies or difficult deliveries, birth trauma, macrosomia, and increased operative deliveries, both vaginal as well as the cesarean sections. So what are the complications after birth of the baby? It is meconium aspiration syndrome, which can lead to fetal hypoxia as well as cardiovascular and respiratory effects. Hypoxia, hypoglycemia because of the less fat reserve, polycythemia, and increased NICU or neonatal intensive care unit admissions. So these are the complications that can occur before, during, and after birth in a post-dated pregnancy. So what are the maternal complications? There is increased incidence of forceps assisted, vacuum assisted, and cesarean section deliveries, that is more instrumental deliveries, then difficulty in delivering of the shoulders, which is called as shoulder dystocia, increased psychological stress to the women, and need for induction. If the patient is not spontaneously landing in labor, then we need to induce labor to prevent prolonged pregnancies, like you have to deliver the baby. So these are the maternal complications. So once we have done, we know the complications, we should, our target is to monitor the pregnancy and go for the successful outcome. So how are we monitoring fetus in a post-term pregnancy? First, we ask the patient to tell us about the fetal movements. So this is a fetal kick count, which is very important, which is an indicator that the fetus is in good health. So regular movements of the baby is the best sign indicating that it is still in good health. The mother should keep a kick chart, that is a fetal kick count chart, to record the movements of the baby. If there is a reduction in movements, it could indicate placental deterioration. So this kick count she has to mark, okay, and it is to the count of Cardiff 10 count she has to monitor. Any reduction in the count she has to immediately report to the hospital. Then the next method is a cardiotocograph. This is an electronic fetal heart monitoring, where we can see the fetal cardiac activity, the rate, the fetal movements, as well as the maternal contractions. So electronic fetal monitoring uses a cardiotocograph to check the baby's heartbeat, and it is typically monitored over a 20-minute period. Okay, this is similar to a non-stress test because the patient is not in labor. So ultrasound scan. If the placenta is deteriorating, then the amount of fluid will be low and induced labor is highly recommended. However, ultrasounds are operator dependent. Actual placenta won't start to deteriorate until 48 weeks. But what we check is the diameters of the fetus as well as the amniotic fluid volume, total volume, as well as the single deep pocket length. Whichever is showing oligoamnios, that is a single pocket less or a total AFI less than 8, we can proceed with the less than 5 is a critical, we can proceed with the induction or explain risk to the mother. Then we have the biophysical monitoring, which checks for the baby's heart rate, muscle tone, movement, breathing, and the amount of amniotic fluid surrounding the baby. So this is the biophysical profile, which after monitoring we give a score to it. That is, the normal score is around 8 to 10. Then the CNS is functional and the fetus is not hypoxemic. Equivocal, if the score is 6, we repeat the biophysical profile, and if the biophysical profile is abnormal less than 4, we can go with the labor induction. So what are all the parameters we are checking in a biophysical profile? Fetal breathing movements. It is more than one episode in 30 minutes, each lasting for more than 30 seconds, which gives a score of 2. And the gross body movements, 3 or more body movements in 30 minutes. Fetal tone, more than one episode of active extension with return to flexion of the limbs. Reactive fetal heart rate, more than 2 episodes of acceleration in 20 minutes, each lasting for more than 15 seconds associated with the fetal movement. And amniotic fluid volume, more than one pocket measuring more than 1 centimeters. So each will give a score of 2 for this, and the total score is calculated as 8 to 10 for 8 to 10. And if it is abnormal score, that is 0, well, we give a score of 0. If there is absent or no fetal breathing episode in more than 30 seconds in 30 minutes, less than 3 episodes of body movement, slower extension with return to flexion, movement of the limb in full extension, or the fetal movement is absent, the score is 0. If the fetal heart rate is not reactive, the score is 0. Absent Leica, the score is 0. Such cases with the abnormal score, we go with the further evaluation with the Dopplers or for induction of labor. Then we have the Doppler flow study, which is very important in determining the well-being of the fetus. So Doppler flow study is a type of ultrasound that measures the amount of blood flowing in and out of the placenta. So we measure these Dopplers at the umbilical artery, middle cerebral artery. And if the Doppler is abnormal, or if there is a reduced flow or absent diastolic flow or a reverse diastolic flow in the umbilical, we proceed with termination, that is, we have to plan for delivery of the baby. Management. In an uncomplicated case of postnatal pregnancy where there are no other associated complications, if the Dopplers are normal, if the Leica is normal, we can proceed with induction of labor and delivery, and cesarean section is only for any obstetric indications. But in a complicated postnatal pregnancy where there are known complications or any high risk factors, then the need for cesarean section can be explained to the patient and a decision can be taken. So the take home message, important message is, please try to do a dating scan in the first trimester or the earliest opportunity available. A dating scan in the first trimester is always more reliable than her last menstrual period, and please check the patient's dates before induction of labor, which is very important, which can also sometimes lead to a preterm delivery. So this is very important message on the dates and calculation of the expected date of delivery of the patient. So what is the reason for the induction in a post-dated pregnancy? Women with uncomplicated pregnancies, where the pregnancies has no other complications like a diabetes, hypertension, or any other risk factors, they should be offered induction between 40 and 42 weeks to avoid the risk of prolonged pregnancy. Okay, the exact timing should take into account the woman's preferences and local circumstances as well as the obstetric factors. So by 41 and 42, she can be offered induction of labor. So before induction, this is an important score which we assess before induction of labor, which is called as the Bishop score. It is a pre-labor scoring system to assist in predicting whether induction of labor will be required and be successful. This score grades patients who would be most likely to achieve a successful induction. So this is based on the parameters like the cervix, position of the cervix, consistency, effacement, dilatation, and station of the fetal head. So this is the 5 parameters, and a score of more than 6 will give a good induction, that is the where more than 6 is a good score for induction. So on the position of the cervix coming, the position is given a score of 0 if it is posterior, 1 for mid position, 2 for anterior. Consistency 0 for firm consistency, 1 for medium and 2 for soft. Effacement 0 to 30%, 40 to 50% a score of 1, 60 to 70% score of 2, more than 80 a score of 3. Dilatation, the score is 0 if the os is closed, 1 to 2 centimeters the score is 1, 3 to 4 centimeters the score is 2, more than 5 the score is 3. Station of the fetal head -3 the score is 0, -2 the score is 1, -1 the score is 2, +1 or +2 the score is 3. And we have the modified Bishop score, where the effacement has been replaced by length of the cervix. So based on this, we see the so along with this we have points that are added or subtracted. So for 1 point is added for preeclampsia and previous vaginal delivery, and 1 point is subtracted for postdated pregnancy, nulliparity, PBROM and preterm rupture of membranes. So this is the modified Bishop score. So this image shows the cervical dilatation and effacement during labor. In the first picture, the cervix is not effaced or dilated. In the second picture, there is 50% effacement or shortening of the cervix as well as, but it is not dilated. And in the third picture, cervix is 100% effaced, that is fully taken up but and dilated to 3 centimeters. And in the fourth picture, cervix is fully dilated to 10 centimeter and completely effaced. So in an uncomplicated pregnancy, we are offering induction of labor. So give every woman adequate opportunity to go into spontaneous labor. So what we do is we offer membrane sweep to the patient, to nulliparous women at 40-week antenatal visit and to all women at 41 weeks to assess the cervix, and before induction we offer the membrane sweep. So this will help in spontaneous onset of labor. Sweeping the membranes in women at term reduce the delay between randomization and spontaneous onset of labor by a mean of 3 days. And after membrane sweep, there is an increased likelihood of both spontaneous labor within 48 hours of membrane sweep. So that is the reason we can offer a membrane sweep to a primary as well as a multigravida woman. So what are the alternatives to induction, including waiting? So membrane sweeping reduces the frequency of formal induction of labor. So from 42 weeks, so what are the alternatives is we can offer induction. If the woman is not willing for induction, we can offer her a wait period or a membrane sweep we can offer, and the last thing will be a cesarean section. From 42 weeks, women who decline induction of labor should be offered increased antenatal monitoring consisting of at least twice weekly cardiography and ultrasound estimation of amniotic pool depth. So this has to be offered to the woman at least twice weekly. So what is the risk? As we have already mentioned, the risk of stillbirth increases from 1 per 3000 at 37 weeks to 3 per 3000 at 42 and 6 per 3000 at 43 weeks of gestation. With routine induction, the perinatal death was reduced and the rate of cesarean section was reduced. So what are the methods that are available to induce labor? We have natural methods, mechanical methods, as well as the pharmacological methods. So what are the natural methods of induction? That will be a cervical stretch and membrane sweep, which will release prostaglandins and onset of labor. Then we have nipple stimulation, sexual intercourse, and acupuncture. So these acupuncture techniques help you to induce labor naturally and have a easier and shorter labor. And what are the mechanical methods that are available? That is the intracervical Foley's catheterization or cervical ripening balloon. So this helps in dilatation and effacement of the cervix. But one advantage of the intracervical Foley's is it will not cause any hyperstimulation of the uterus. So this is one importance. So that is why it can also be used in a patient with a previous cesarean section. So what are the other mechanical methods that can be used? It is the intracervical laminaria tens or the dilapan, which is a intracervical method to help in dilatation of the cervix. After the mechanical and the natural methods, we have the pharmacological methods, which is with the help of prostaglandins, that is PGE1, that is misoprostol. Then PGE2, we have the preparations like dinoproston, that is a gel, or prostin vaginal tablets, which are available. So these are the methods, pharmacological methods, that help in induction of labor. So this is a prostin pessary introduction into the vagina near the cervical canal, which helps in release of progesterone release, which is a prostaglandin and helps in induction of labor. So what are the risks and side effects associated with induction of labor? Induction of labor as such is not a very safe process, and because of the pharmacological methods used, because of the prostaglandins, there are always complications like which is a routine complication, fever, vomitings, diarrhea, and specific complications to pregnancy, that is the uterine hyperstimulation, fetal distress, and also it is a failed induction. So what is uterine hyperstimulation? It is defined as more than 5 contractions per 10 minutes, and which can also have an effect on the fetal heart rate, which can cause fetal bradycardia or reduce in the baseline of the fetal heart rate. Then which can also cause fetal distress, and the last thing is the failed induction. So why is this induction important? Because it can have medico-legal as well as implications. It is very important that we take a consent before we proceed with induction. Consent and risks we can explain all of hyperstimulation, meconium aspiration syndrome, sometimes if it is a case of previous LSCS, ruptured uterus. So all these complications have to be informed, and consent is very important before we do a procedure. So what is the next step if induction fails? We have given induction 2 to 3 doses we have given over the time period of 48 hours. What next if the induction has failed? We can go with the expected management that the labor will ensure. We can just wait and watch. Reinduction after the lag time, or a lower segment cesarean section, which can also be done. So this is if the induction fails, the subsequent management options include further attempt to induce labor or a C-section. So where are we going to induce labor? In a hospital for the post dates more than 7 days, that is 41 weeks pregnancy, GDM or the gestational diabetes mellitus patient on treatment at 38 to 40 weeks, that is if she is on insulin, or a type 2 diabetic on insulin at 37 to 38 weeks, patient with PIH or preeclampsia at 38 weeks, PROM after 24 hours of time. And GDM, if she is not on any treatment, then we can induce labor at term, that is on EDD. So what is the procedure before induction? We do a CTG prior to insertion to see if it is reactive, and Start with induction of prostanet, preferably in the morning 5 or 6 o'clock, so that we can review the patient with the CTG and check during the morning rounds at 9 o'clock. For the cases of previous LSES and grand multipara, Foley's catheters have to be kept in situ for induction for 24 hours. Thank you.